اوكي، تفضلي دكتورة.
اوكي، السلام عليكم ورحمة الله وبركاته. موضوعنا اليوم هو Risk and Prognosis of Diabetic Ketoacidosis in COVID-19 patient. ومثل ما قلت أحاول أنقل ال UK experience بالمانجمنت في هذه الحالة. ليش أنا اختاريت هذا الموضوع؟ إنه COVID-19 appears to influence the natural history of DKA. COVID-19 precipitates severe manifestation of diabetes, including diabetic ketoacidosis, hyperosmolar hyperglycemic state, and severe insulin resistant. So multiple studies have showed that hyperglycemia in both people with or without diabetes is an important risk factor for death in COVID-19. فالعبرة من هذا الموضوع أنه COVID-19 it's increased the risk of hyperglycemia, whether the patient is known to have diabetes or not. كيف عرفنا هذا؟ في multiple studies مختلفة عملوا observational studies and لاحظوا أنه patient with COVID أما هم non-diabetes or not non-diabetes, or both have showed their increased mortality rate. ليش السبب؟ There's some like connection or some precipitating factors COVID cause hyperglycemia in those patients and end with high mortality. We are going to throw some lights about these studies later in different slides. Diabetes behave as one of the main causes of morbidity and mortality in the world, and this condition is associated with severe micro and macrovascular complications that impact patient survival. Several studies indicate that patients with diabetes, and especially those infected with SARS-CoV-2 virus, have higher rate of hospital admission due to development of severe pneumonia, also high mortality rate when compared to patients without comorbidities. So this example of a case have been published in Diabetic Metabolic Syndrome in PubMed. In this patient, who is a 13-year-old, presented with general weakness, fever, loss of taste, and mild dyspnea for 6 days. He tested positive for SARS-CoV-2 by PCR assay. He was initially managed at home. However, his condition worsened and presented to our emergency department with progressive breathlessness and unresolved fever. Patient reported no prior history of diabetes or any other comorbidities. He has no family history of diabetes. Observation on triage, he had blood pressure of 152/84, heart rate of 122, and respiratory rate of 24. His body temperature was 37.7 and oxygen saturation was around 90 on room air. Okay, I'll give you like 1 minute just to read the case scenario because it's important later how we manage this case and we are going to discuss the pathophysiology, pathogenesis of all these symptoms and observation. Okay, let's move to blood investigations. So initially, in any patient come to the emergency department, in such case, this patient looked acutely ill. So bloods will be taken immediately or at the triage. And one of the initial blood tests we do is venous blood gas. And there's like in our department, in my department, we have 2 blood gas machine. So we can do it on the bedside. So at least you can have like this immediate parameters, which is the pH, bicarb, glucose, serum ketones, and some electrolytes as well. So in this patient, his pH was 7.07, bicarb was 6.1, glucose, this 30, which is millimole per liter or 540 milligram per deciliter. I'm not sure what unit you use in Libya. Serum ketone is 6 millimole as well. Hemoglobin 14.5, white blood cell is 13.6. Just go back. His sodium was 131, potassium 3.9, chloride 110, creatinine was 0.7, anion gap was 11.9, lactate was 1.22, and interleukin 6 is 60, CRP is 156, and D dimer is 900. Of course, this will not immediately, we have all the tests. For example, we don't usually do interleukin 6 in our department, but later we'll just tell why I mention it in this case. Okay. So, Dr. Mohammed, can you show this questions? So according to the case we have discussed just now, what is the first priority you have to provide in this patient?
دكتورة كان ترجع للسلايد اللي قبلها. It looks like إنه هو severely acidotic وهايبرغلايسيميا والكيتون والبايكارب though most probably metabolic acidosis. فشنو الفيرست priority في الكيس زي هذه؟ تقريبا أغلبكم ماشيين في الاتجاه الصحيح للإجابة.
أقول الإجابة دكتور محمد.
خلينا تمام، حنوقفوا السؤال.
طيب.
يس، هذه الريزلتس المفروض طالعة.
طيب
اللي هو
ممتاز.
71% مجاوبين الصح تقريبا.
فاحنا انا سأقول لكم ليش الفرق، ممكن ليش ناس تكتب انسولين او لا. احنا اعتقد كلكم عرفتوا انه الدايجنوسيس هو diabetic ketoacidosis. ليش نعطي فلويد بالبدايه؟ لانه patient is very dehydrated. ممكن الانسولين، هو الانسولين صح والبوتاسيوم كلها صح للنطيب بس not immediately. The first line it should be fluid. Patient is severely dehydrated. He is having, as you see in the case scenario as well. Sorry, I cannot go to the previous slide. No. He had high heart rate and high respiratory rate. So the patient have some sort of shock as well. That's why he need fluid as a first line of management. Why we don't give insulin or potassium, we are going later discussing step-by-step management and which one we should prioritize than the next one. Okay, so the answer, as you say, is IV saline or normal saline. Okay, so we are going to do some, throw some light and on pathology of DKA and what is the relation with the COVID-19. So I think that's from Tentinelli. If just brief through, I mean, the pathophysiology. So as we know that whether it's type 1 or type 2, there's some insulin deficiency which reduce glucose utilization by the cell and increase hepatic glucogenesis, and this will lead to hyperglycemia. Hyperglycemia itself is the serum glucose is high, but the cell still not utilizing it. So the cell still need a source of energy, and the source of energy will come from glucogenesis, which is that one. And this will lead to lipolysis as well, because we are going to change the lipid or fat acid to glucose, and this will lead some harmful product. Anyway, when the blood sugar will be high, this will increase the glucose-urea, which will lead to osmotic diuresis. And when there is diuresis, which the symptoms show as polyuria, I mean, the patient will describe it, this will end with dehydration and shock. And that's why fluid should be as number one. Lipolysis itself or this breakdown the fatty acid will cause later increase in ketones or keto acids. And this also will increase the anion gap. Metabolic acidosis will cause further dehydration and shock. Okay, so Dr. Mohammed, this is the next question. So as we mentioned, what do you think that the cause of hyperglycemia in DKA? So one of them is wrong, all the rest are correct. So except which one is not correct?
تمام تقريبا. مفترض أن نوقف السؤال. إذا كان في ناس تبي تجاوب حنوقف، حاولوا تجاوبوا لأن بنقول ستوب. تمام، شكرا. أغلب 36% جاوبوا
صحيح.
بي.
طيب هو سؤال شوية تريكي، لأنه هو glucogenesis صحيح زاد يعني، بس هي لأنه هو not in the kidneys. يعني هو what will happen is glycogen store in the liver. Glycogen will be changed into glucose, so that's why number 1 is correct. Number 2 is wrong because it's not in the kidney. Gluconeogenesis happen in the liver and adipose tissue as well as skeletal muscles, so it's not in the kidneys. Serum glucagon will increase. Increase gluconeogenesis, as we say, in the adipose tissue, and decrease glucose uptake from the muscle, as we say, due to the deficiency in insulin. Okay. So after we understand a little bit or review the pathogenesis or pathophysiology of DKA, now we want to know what is the relation of hyperglycemia with the COVID. So the exact pathogenic mechanism involved are yet not to be determined. However, the role of inflammatory cytokines released during the viral illness has been implicated. So in this graph, it showed different mechanisms can explain the relation between COVID and hyperglycemia. So one of them was being explained, or later we're going to explain the relation of COVID with ACE2 enzyme. And this will lead to increase in the angiotensin 2, and angiotensin 2 cause oxidative stress. As we know, stress in particular increase the stress, and that will increase glucose level. The next mechanism is autoimmune status, and this will have autoimmunity and will cause further damage to beta cell in the pancreas. Another pathophysiology is cytokines storm increase, and this will cause to increase insulin resistance. Okay, and the last one is pancreatic cell damage. So there is a direct damage to the pancreatic cell by the COVID virus, and this will lead to hyperglycemia and whatever end with diabetes type 1 or 2. Okay, in the next slide, I'm going to explain more about this pathogen. So in COVID-19, it might aggravate pancreatic beta cell function and precipitate DKA in patients with pre-existing or new onset diabetes, as shown in that one we explained before. Interleukin 6 level have been shown to be elevated in both DKA and COVID-19 and may be an important prognostic factor. So initially, when I explained the blood test, I told you that interleukin 6 is usually we don't really do it as an emergency department, but that's for the purpose of a study. I just showed why interleukin was high in that specific patient. So I say in our case, interleukin 6 level been rated. There was no previous history of diabetes, and the severe DKA episode that occurred leading to hospitalization in intensive care setting might be due to or triggered by the effect of COVID-19 on the diabetes. So it's just to show that the high level of interleukin 6 It might be because the COVID itself cause or precipitate severe DKA. So the presence of interleukin-6, high level of interleukin-6 in our patient can explain that part of what we call cytokine storm theory. Okay, the other rule, which is the ACE rule, there's some interaction between SARS-CoV-2 and the renin-angiotensin-aldosterone system, which can provide another mechanism in the pathophysiology of DKA. This enzyme is crucial enzyme in the RAAS system, which is catalyze the conversion of angiotensin 2 to angiotensin. ACE2 is highly expressed in the lung and pancreas. It's okay, so that's maybe just a little bit confusing because we are usually know the ACE, not ACE2. So in this paragraph, I'm showing you, if you remember that angiotensinogen, which is this enzyme or this is product which is produced by the liver, with the action of renin, it will turn to angiotensin 1. And then angiotensin 1 will travel to the lung, and with the action of angiotensin converting enzyme, it will make angiotensin 2. Angiotensin 2 then will cause this effect, vasoconstriction, pro-oxidant, inflammation, pro-fibrosis, pro-apoptosis. If you just remember the pathophysiology of AS or heart failure, when patient being diagnosed with ACS, one of the first things we have to consider to give the patient ACE inhibitors or ARBs. Why? To stop this process, which we call the remodeling. So if the patient have ACS and ACE is being, angiotensin 2 will be high, it will cause inflammation and fibrosis, and the patient will end with dilated heart failure because of this fibrosis. There will be change of the muscle, cardiac muscle, into fibrous tissue. Okay, I want you to understand what is angiotensin 2. So in this angiotensin 2, because it's a quite powerful action, so the body have a counter action, which is this angiotensin 1 to 7. And how this will be formed by another enzyme, it's called angiotensin converting enzyme 2. Okay, this angiotensin converting enzyme 2 will change angiotensin 2 to angiotensin 1 to 7. So they are not the same. So we have angiotensin 1, we have angiotensin 2, and we have angiotensin 1 to 7. That is just the name, because there's some like change on the, just difference in amino acid, how many amino acid on the outer layer of that hormone, it will change the analog of the hormone. So angiotensin 1 to 7 is the counteract for angiotensin 2. So it will cause the opposite actually: vasodilation, antioxidant, antifibrosis, anti-inflammation, and anti-apoptosis. So what is the relation here? I mean, why do you think COVID have some problem with ACE2? So if you go back to this slide, the ACE2 is served as entry point for SARS-CoV-2. So expression of ACE2 will be downregulated after endocytosis of the virus complex. Okay, so just imagine when you have a cell which is have the ACE2 receptor on the outer layer, the COVID virus will attach to this receptor and then will go inside the cell and would end with endocytosis. So the cell will have an autoregulatory mechanism because there is many viruses attaching to this receptor, so there will be downregulation. So there will be less expression of ACE2 receptor on the outer cell. That means the action of ACE2 will not be done or will not be like expressed, because there will be no enough receptors in order to cause the action of angiotensin 1 to 7. Okay, so in this slide is showing that whenever the angiotensin 2 is more than angiotensin 1 to 7, that means the patient will end with severe COVID. while the opposite will end with better prognosis. Okay, so as you see here, if this part of the scale is heavier, then COVID-19 is worsening because there's vasoconstriction, there's infection, there's fibrosis. While if this part of the scale or this arm of the scale is heavier, then COVID-19 will improve outcome. So this actually taken from, I think it's a graph from an article have been published in PubMed as well. So a higher ACE to ACE2 ratio may increase the risk of worse outcome in COVID patient. Okay, I know it's a little bit confusing. It just show the relation of why COVID is being like, it's been like discussed earlier when the COVID being discovered, and they mentioned why ACE medication should be stopped with patient with antihypertensive or with hypertension. Anyway, so this inflammatory mechanism can aggravate the hyperglycemia and the action on pancreas. Okay, there is another theory, let's say, or another pathogenesis related to COVID. So in addition to COVID itself, hyperglycemia, which we explained earlier, they found also COVID-19 can cause ketosis or ketoacidosis with or without hyperglycemia. So in a study have been done by Lee J. et al., which includes 658 patients who have been confirmed with COVID. From out of this number, 6.4 patients have been found to have ketosis, even without presence of fever or diarrhea. And those patients had longer length of hospital stay and high mortality rate. How we find this patient, or those patients have high mortality rate? Following up with those patients, 15 patients have diabetic ketoacidosis, and 3 of them have developed acidosis. 5 patients with diabetic ketosis have died, and 1 of these presented with acidosis. Okay, so let's repeat that again. We have 658 patients. 42 of them have developed ketosis. From this 42, 15 patients was diabetic ketosis. That means ketosis plus hyperglycemia. From this 15, 3 patients develop acidosis. So that means from 15 patients, we have 3 patients have DKA. Okay. From this 15 patients, 5 patients have died and 1 have developed DKA. That means not all the DKA have died. So the ketosis is the risk factor, not the hyperglycemia. That's what show in the study. Okay, another 4 who have no diabetic ketotic patient. That means 4 out of these 27 have no hyperglycemia. They also developed severe acidosis and died. So this study suggests that COVID-19 infection cause ketosis or ketoacidosis and induce diabetic ketoacidosis for those with diabetes. Okay, so I know there's a lot of numbers and that can confuse us. It's just the conclusion أو الاستنتاج إنه المرضى اللي presented with COVID or severe COVID because they require admission, 6% of them, they have ketosis. From this 6%, there's some percentage of people who died, okay, even not as a DKA, just with the presence of ketosis. So, as I say, the ketosis increase length of hospital stay and mortality. Meanwhile, diabetes increase the length of hospital stay for patients with ketosis, but do not affect their mortality. Okay, so it's these different studies, but not mean that study is correct, the other study is correct. We are just like understanding the observations have been done by those researchers and to identify the risk factors of prognosis for patient presented with ketosis or hyperglycemia related to COVID patient. Okay, so it's just like telling us, I mean, if we identify the patient earlier, then we can like provide them with better treatment or like better monitoring to reduce the mortality. Okay, so after we have discussed the pathophysiology, let's go to the main thing, how we manage those patients. Okay, so how we manage by, as we mentioned before, when patient come from the ambulance or any acute ill patient present to the emergency department, the first thing we do is triaging the patient. And when we identify patient immediately he's ill, we are going to do blood tests, and the immediate blood test is the venous blood gas. So it can tell us immediately is this patient's DKA or not. Okay, so what are the criteria? This criteria actually from a NICE guideline, which is the UK guidelines. It's maybe a little bit variant from the US guidelines, but I'm trying to just focus on the United Kingdom guidelines. Maybe I will throw a little bit of update from the American side as well. Okay, so the diagnostic criteria is the presence of all of the following. So all the three should be present in order to diagnose DKA. The first one is capillary blood glucose above 11 millimole. In milligram, it will be around 250. And capillary ketone above 3 millimole, or urine ketone 2+ or more. Venous pH less than 7.3, or bicarb less than 15. Either one of them you can consider as acidosis. Okay. So mainstay of management include three main lines, which is the fluid resus, potassium, and insulin treatment. Okay, so as we mentioned in the questions showed earlier, bicarb is not really an immediate option. Usually we keep it only when patient presented with severe acidosis or myocardial depression, or maybe cardiac arrest. So usually bicarb is not really, we don't really use it in emergency department in DKA patient. Okay, so this algorithm is from, as I say, NICE guideline. NICE guideline is the national guidelines in the United Kingdom. And this algorithm is a timeline management. So every hour or every timeline, there's actions and target you need to do it in order to improve the outcome of patient presented with DKA. Okay, so this is immediate management time, which is 0 to 60 minutes. So once you identify this patient is a DKA and the triage, patient should move immediately to resus, or we call the red zone, depend what you call it in your hospital. And you are going immediately to start with fluid. Okay, 0.9 sodium bicarb, 0.9 sodium chloride, which is the normal saline. And this the next action is you start your fixed rate IV insulin. The IV insulin, we targeted dose as 0.1 unit per kg per hour, and then with the monitoring, you might increase or reduce. The next action is you need to assess the patient. So you are going to take his vital signs, his GCS scale, and you have to do full systemic examination. Action number 4 is you need to do additional investigation. So we mentioned about venous blood gas. We can mention about the blood sugar itself. We can add a full blood count, renal function. UNEs mean urea and electrolytes, or we call the renal function test. Blood cultures, because whenever there's patient come with DKA, we have to do blood culture as a precipitant factor. ECG, chest X-ray, and urine test. The next action, we have to start monitoring. So we do hourly measuring of blood glucose, hourly blood ketones, and hourly initially check for venous blood gas, for bicarb and potassium. And for the rest, we can do it, for plasma electrolyte, we do it every 4 hours. And of course, patient needs continuous cardiac monitor and pulse oximetry. And direction number 6 is consider and precipitating cause and treat appropriately. Okay, the next hour after you finish the first hour, so if you just to say in the first hour, mainly you're fluid, insulin, assessing the patient, do more investigations and monitoring. In the next hour, your aim is to reduce the ketones 0.5 millimole per liter per hour, or bicarb increase 3 millimole per liter per hour, and blood glucose fall 3 millimole per liter per hour. Maintain serum potassium within the normal range and avoid hypoglycemia. So that's the aim. How we do that? By frequent assessment of the patient, continuous fluid replacement, and assess response to the treatment. So reassessing the patient, we have mentioned that we need hourly blood glucose, hourly blood ketones, and venous blood gas for pH, bicarb, and potassium, initially after 1 hour, then later after 2 hours, and 2 hours hourly after that. That means every 2 hours you need to do venous blood gas. If potassium is outside the normal range, then we have to correct accordingly. I'm going to explain that in the next slide. Continue fluid replacement is, as we mentioned, in the first hour, we are going to give 1 liter. We give another liter in the next 2 hours, another liter in the next 2 hours, and another liter in 4 hours. Okay, we have to add glucose when the blood sugar falls below 40 millimole per liter. Okay, so I know that is a lot. So the good thing that we have it in the UK, every emergency department, we have this called DKA prescription. This one actually from Leicester Hospital. This is present online for reference. I couldn't get my the one from my department. Anyway, so what we do here, we are going to put the patient details here, and his initial blood sugar, ketones, and everything. All these 3 parameters should be, if you can see here, it should be mentioned here. Okay, so that is just showing us the guidelines, and what we do only we tick it and we sign it. Very comprehensive and not confusing. And if you can see here, the first page focused on the IV fluid. So if you can see here, the first liter should be given over 1 hour. So here, if you can have 500 ml per 30 minutes. So you can, if it's 1 liter, that's all. You sign here, write your name and the nurse who's giving the fluid. And here we'll give like more details if the patient have like a kidney failure or heart failure, or you have to reduce the fluid. If the patient is in shock, then we need to give less fluid in the beginning. The second liter, the second hour after 60 minutes, we are going to start your second liter and do the same. We just, the good thing is you are not going to write anything. You just write the time and you sign it off. Okay, and as we mentioned, every 1 hour we are going to check the ketones and pH. Okay, once the blood sugar is reduced less than 14, we are going to start prescribing glucose. So that's one for the fluid. For potassium, we are going to prescribe as according to the level of potassium. So if the potassium level, if we go back here, okay, if you go back here, we don't see here any potassium, okay? We are not seeing any potassium here. Why? Because the potassium we will consider in the next hour. So if the potassium is below the normal range, then we are going to give KCl with the fluid. If it's more than the normal range, we are just continue with the insulin, because insulin is going to bring down the potassium. Okay, so if you see here, That's why the patient have low potassium. We are going to add potassium chloride to the first liter of normal saline. And all these details about the diagnosis of severe DKA or the criteria for admission to the intensive care unit is all being mentioned in this prescription notes. Okay, so as I mentioned about the potassium, it's just I want you to give some attention. When the VBG, initial VBG or venous blood gas show potassium is very low or less than the normal range, which is less than 3.5 here, then here you should not start insulin therapy. You have to withhold the insulin, do fast correction of potassium by adding 20 millimole, or sorry, we add 40 millimole of KCl to 500 ml of normal saline, and you give it over 1 hour, and then you repeat the KCl, repeat the potassium level. Once it's starting to become high, then you can start the insulin, because as we mentioned, insulin itself is going to bring the potassium low. So if it's already low, that may cause it quite severely low and cause some cardiac complication. Okay, the insulin, how we give insulin, why we give it in the beginning, as we mentioned, because here we know already the potassium level, but if we don't know the potassium level, that's what is recommended by the American guidelines. Usually the first 30 minutes, we give only fluid. Only when you get the serum potassium level, then you decide to start insulin or not. But in the UK, with a venous blood gas, you should be available immediately, so you can decide to start insulin or not. Okay, so insulin, we usually start with short acting, we call it Actrapid, the one we use in our department. And we can start with 0.1 unit per kg. That's in the first hour. In the second hour, when we are going to repeat the serum glucose, pH, and ketones, if there is no improvement, then we can increase as 0.1 unit per kg per hour. So you double the dose until you can, over 1 hour, until you can get the targeted reduce in ketones and blood sugar. Okay. So what is the modification that we need to apply in treatment of DKA patient who being presented or precipitated by COVID infection? So the first thing we do is, of course, is the personal protective equipment. We have to wear our PPEs, and we have to minimize the duration or the contact between the medical team and the patient as much as possible. Okay, the modification on fluid therapy, if you can remember the chart we have saw for fluid, there's a lot of fluid we are giving to the DKA patient. There's around maybe up to 10 liters of fluid we are going to give the DKA patient. With the presence of COVID infection, which is very inflammatory, has induced a lot of inflammatory process, and this will put the patient at risk of acute respiratory distress syndrome, which is like non-cardiogenic pulmonary edema. So we have to be cautious with giving excessive fluid resuscitation. Therefore, proper fluid management is vital in these patients. What we do usually, if we consider this patient a severe DKA, patient should go to the intensive care unit. And one of the things they will do immediately is inserting a central venous line to monitor the intravenous fluid status. So at least this will help us in giving adequate volume of fluid. In addition to that problem, angiotensin II can stimulate aldosterone secretion, and this can potentiate the risk of hypokalemia, which may necessitate more potassium supplementation in order to continue IV insulin to suppress genesis. What that mean is, remember, in COVID infection is going to suppress the ACE2 enzyme, which will favor increase in angiotensin 2. So angiotensin 2 have a lot of side effects, including accumulation of aldosterone, and this will cause kalemia. And we know that we are going to give insulin for very long duration can cause worsen hypokalemia. That's why it's important to monitor potassium level. Okay, the next thing we need, there's some studies suggest modification in insulin is, as we know that all DKA patients, they will receive intravenous insulin. Some data support that it is safe and effective to give subcutaneous rapid-acting insulin for DKA. For these reasons, subcutaneous insulin therapy have been used in patients with uncomplicated, mild or moderate DKA. So in those patients with DKA or HHS, subcutaneous insulin protocol rather than IV insulin infusion were adopted early in COVID-19 pandemic to treat mild to moderate diabetic ketoacidosis or hyperosmolar hyperglycemic state, when IV insulin was less feasible owing to the need for limited frequency of contact of staff with patients. So as we explained earlier, the aim when we treat COVID patient is to reduce or minimize the contact of the medical staff with the patient. So one of the things they suggest, if we give subcutaneous insulin, we are going to do less monitoring. We don't need to keep prick the patient to do blood glucose every 1 hour. Okay, if we give IV insulin, we need to monitor the patient hourly. But if we can give subcutaneous insulin, this will increase the monitoring time up to 2 to 4 hours rather than hourly. So that will minimize the contact with the patient. As we mentioned, that's only indicated for mild to moderate DKA, which is pH more than 7, serum bicarb is more than 10, serum potassium is more than 3.3, and the patient should be awake and his mental state is adequate. Okay, while for severe DKA, insulin should be given as intravenous infusion. Or complicated DKA with acute heart failure, patient have end-stage renal failure, acute liver failure, and a SARCA, weight more than 120, treatment with high-dose corticosteroid, or pregnant women. Okay, our target in COVID-19 patient is to control his glucose level. I think this, control or glycemic control is in all acute ill patient, not only in COVID patient. But here in general, the goal of treatment is the same as other hospitalized patient, is to avoid severe hyperglycemia, volume depletion, and electrolyte abnormalities, avoid hypoglycemia, and ensure adequate nutrition. So a blood glucose target is usually 7.8 to 10. It means it's not necessary to bring the blood sugar to the normal range. It's considered as a reasonable for most hospitalized patients. Many patients have severe insulin resistance and require high dose of insulin to achieve these goals. Okay, another point I just need to bring your attention is to when patient is diabetic, a lot of patient is on oral hypoglycemic agent, and one of them is sodium glucose co-transporter inhibitors. So this type of what is the things that is important to recognize on patient taking this medication? They can present a DKA with normal blood sugar. So that's sometimes say no, he doesn't have hypoglycemia. You have to check, is patient taking any medication which can cause normal blood sugar? So that is important to take, in the past medical history. So DKA is frequently associated with marked hyperglycemia, which is a feature once absent, is difficult to diagnose DKA. But in presence of sodium glucose cotransporter inhibitors, it might be difficult. So in this case, blood glucose level can be not normal, it's high, but not as high as need to diagnose DKA. These individuals during the COVID pandemic may be at increased risk of DKA. So it's important to advise this patient to stop taking this medication when they have flu-like illness. Okay, so we go to the main conclusion of our presentation. Severe illnesses manifested as the need of hospitalization, intubation, and death can occur otherwise in healthy individuals of any age, but the risk of severe illness is most pronounced in adults with advanced age or underlying medical comorbidities, including diabetes. So this is all. I mean, all patients presented to our hospitals, there's some criteria that they increase their outcome. So the outcome is usually measured by how long they need to stay in the hospital, do they need to be intubated, or what is the outcome? If the outcome, it might be death. Okay, so the emerging information suggests that individuals with diabetes are at increased risk of complication, including death, among COVID-19 patients. According to a clinical report in China involving 1,099 confirmed COVID-19 patients, they found that diabetes was the second most comorbidities among severe 173 cases. So so this is also observational study done on 1,000 COVID or confirmed COVID patient. From this 1,000, there was 173 cases, severe cases, and some of them died, and they found that diabetes was the second most common comorbidities. There are not enough evidence to determine the risk of diabetes for poor outcome in COVID-19 patients yet, but a small study showed that COVID-19 patients with diabetes were not only at higher risk of severe pneumonia, but also to release excessive inflammatory biomarkers. Okay, so in this slide, I'm showing you some three types of studies have been done. This one in China, this is in the United States, and this one in the UK. So these studies, they found that patients with type 2 diabetes are more likely to have serious complication, more intensive, and more ICU admission, and longer length of stay and death from COVID-19. So in these studies, they found that even like the type 2 diabetes, they are higher risk than even type 1. So in this study that's done in China, they found there is 7.3 among patients with diabetes, and most likely is type 2. The overall cases fatality rate was 2.3. And in the United States, the mortality